Hi, John. Great. Thank you very much for the invite. Delighted to be here.
Perfect. It's a pleasure. Are you happy for me to hand over to you and to discuss your colleagues who will be joining us and about everything that's going on next?
Yeah, fantastic. Let me know when you want me to take over.
Yes, lovely. I'm ready when you are.
Okay, great. Thank you very much. Kieran Walsh is my name. I'm Clinical Director at BMJ, and I'm going to give a short case-based presentation on BMJ Best Practice, and hopefully we'll have a short panel discussion at the end with my colleagues, Doctors Amal Mayer, Eva Brady, and Angelika Sharma. Um, so to dive into the subject of BMJ best practice, improving clinical decision making. First of all, a few slides about evidence-based medicine, because clinical decision support should be about the implementation of evidence-based medicine. Gordon Guyatt first coined the phrase evidence-based medicine in 1992, and he talked about the need for a shift from intuition on systematic clinical experience and pathophysiological rationale to scientific, clinically relevant research. And the definition has gone through iterations down through the years, but we like this graphical definition that says evidence-based medicine should be about the best available research, resources, including practitioner and professional expertise, and population characteristics, needs, values, and preferences. And yet, there are challenges to doing this and challenges to the implementation of evidence-based medicine. When I was a junior doctor years ago now, you could still learn off treatments for common conditions. It's really not possible anymore. And just picking on one of them, the interleukin 6 receptor, and they're indicated, there's a massive amount of knowledge about them, a great deal of detail required. But even commonly prescribed drugs like steroids, there's a great deal of detail needed about them. What type of steroid should you use? What exact drug should you use? Under what circumstances? And that's part of the reason why we make more and more use of infographics in trying to portray this complex information. We also need to know the dose, and therefore we need links to relevant drug formularies like the BNF, the British National Formulary, also the BNFC for children. And what if your patient were to develop long COVID? Well, then you need to know a massive amount about the drug and non-drug options for treatment of this condition. And back to the patient, we need patient information leaflets so that the patient is fully informed, and therefore we can close the circle of evidence-based medicine. And we try and do that with BMJ Best Practice as well. So I know I've zipped through that in the interest of time, but what we're trying to do here is deliver evidence-based care with updated guidance, and that's a challenge also because our guidance has to change every couple of weeks in COVID-19, and deliver actionable recommendations which can be put into practice at the point of care. And I hope, if nothing else, I've shown the enormous complexity of doing this, the challenges that doctors and other healthcare professionals in primary care and secondary care are up against in trying to deliver. So back to BMJ Best Practice. Essentially, it's a knowledge resource that answers clinical questions, but it doesn't just give any answer. It focuses relentlessly on what is important to our users. And what's important to our users is speed. They want answers quickly, within seconds. They want practical, actionable information for use at the point of care that can deliver clinical quality improvement. They want to be assured that the content that they have is continually updated and evidence-based, and they want to be able to access it on a mobile, on an app, online and offline. More about that in a second. And so that's what we try and do with BMJ Best Practice. It's a digital knowledge resource that's comprehensive, covers 1,000 topics. Continually updating. We used to update annually, but would now move to a continuous updating process whereby we get new evidence into the content all the time. And the browse and search, I'm not going to touch on them. Needless to say, it's all about speed, really, speed to an answer. This work you hear from senior doctors and other healthcare professionals and juniors also all the time. They don't want things that will interrupt their clinical workflow. When something important changes, we put it on the homepage, and people want to access it in a variety of different ways, and sometimes in traditional ways, like PDFs that they can print out and read in their own time, and we enable that as well. Increasingly, and I showed you a part of a treatment algorithm earlier, but this is the most valued and useful part of the site. Treatment algorithms to guide the users through treatment options, first line, second line, and so on. And this is interesting because it's a step towards personalization of the evidence. So it's directly relevant to the patient in front of you. And we update the content all the time. Here's just some examples of content that we updated in one day last month. When something important changes that is important to our users that they've looked at in the past, we send them a notification. We don't send them all the time, and we only send them when they're directly relevant to the person's previous activity on the site, and we've found that that is popular. People want more than just the knowledge resource. They want a range of different resources available to them that they can use where and wherever they are in whatever circumstances. Just one of these is medical calculators. And so without interruption to the medical workflow, you can use medical calculators and work out everything from a patient's body mass index through to Apache score. Patient information leaflets, a really important part of the circle of evidence-based medicine, written in layperson's language, aimed at a reading age of 12. The patient's role in evidence-based medicine is important, and so our patient information leaflets parallel the professional content and at the same time are continually updated. It's not just about knowledge, sometimes it's about skills, and sometimes procedural skills that need to be put into practice at the point of care. And so we have procedural skills videos, which are short, 3 or 4 minutes long, but show you the essentials of a procedure. The site is increasingly image rich. You only put clinical images that are relevant in context for the users, and therefore it really supports certain specialities from dermatology, ophthalmology, cardiology, and radiology. Sometimes people don't use clinical decision support, and you ask them why. And they say the reason why is because they don't understand what's behind the clinical decision support. They ask themselves, why am I getting these messages? They want to know what's inside the black box of clinical decision support. And so we're upfront and transparent about this, and we show the evidence-based that underlies the recommendations, and part of the evidence-based for BMJ Best Practice comes from Cochrane Clinical Answers, which is based on Cochrane Reviews, which is a database, a compendium of best available evidence. But it's not just that, it's also about best of breed national and international guidelines that are relevant to users. While all this is happening and while you're searching and using the resource, our continuing medical education or continuous professional development tracker is recording your usage, and then you can create a certificate of activity on the site showing what you've been looking at and when and how much time you've spent on the site, but also you can add reflections of how you've used the content and also add details on the impact that the content has had on your clinical practice. We provide the best available international evidence, but we also know that many healthcare professionals want to find out about local guidelines, and so we enable institutions to add their local guidelines to the site as well. at the start that mobile is really important to increasingly all our users. I used to say our younger users, but today I can say pretty much all our users. And so we've a mobile optimized version of the site as well. The app is also really important. When I give this talk, one of the first questions I get asked about is the app and what's on the app. And we've done a lot of work on the app over the last few years, and we now have a resource that has a very fast download time, uses minimal storage, is only available offline, and increasingly you get the same experience in the offline app as you do on the live site, which is what our users want. Last point about access is that increasingly access is all about integration of the content into the electronic healthcare records. And I think this is something we'll be hearing much, much more about in the next 5 years. And we can offer and support different levels of integration from search widget, very simple, through to HL7 info button, through to deeper, complete API integration, which provides complete flexibility in how our clinical information is displayed within the electronic healthcare system. Why do all this? Well, it's about speed, so get an answer, an exact answer to your question within seconds, and also without any interruption to the clinical workflow. It's really important to our users. I don't have time to go into this in a great deal of detail, but we've also recently added a new addition to the site, the Comrabilities tool, so that you can add the patient's comorbidities to an existing management plan and get a tailored plan, which of course has become vitally important in the COVID pandemic, where we know so many patients with comorbidity end up seriously unwell in hospital or intensive care. Now, I started off with a critique of evidence-based medicine in some ways, but of course, we have a robust evidence process from information specialists through to clinical editors, external peer reviewers, pharmacist editors, digital content editors, etc., etc. So we have a resource that is explicitly evidence-based and that you can rely on. And we also use GRADE as part of our evidence process so that you can find out not just whether treatment works or doesn't work, but in what particular population, exactly what intervention compared to what comparison achieves whatever outcomes, and how much confidence you can have in the evidence as a result. Lastly, and importantly, clinical decision support relies upon the evidence. The evidence has to be transparent. It has to be transparent and independent, and also patient-focused. And here are our values at BMJ, and we try and make these living, breathing values that we put into practice every day in our work. I'm just going to put my email address here. If any of you have any questions after the event, please do get in touch. But I'm going to stop sharing my screen now, and I'm going to hand over to the panel and ask the panel to spend the next 20 minutes discussing evidence-based medicine, clinical decision support, and their experience with the resource. Top right of my screen is Angelica. So why don't we start off with yourself, Angelica? Can you give us some examples of how you might have used BMJ Best Practice in clinical practice?
Sure. So I'm currently in FY2 at the moment, but I actually started using BMJ Best Practice back in medical school. So it offers a great overview of a condition right from the pathophysiology, etiology, and then going on to what components make up a good history. So when I was practicing for my clinical examinations, I was always flick through the conditions according to the learning objectives and have a look at what features I need to really elicit from the history. And then it flows really nicely back onto the pathophysiology. So often you get asked questions about the underlying mechanisms and also the different etiologies. Then moving on, as I became more senior, we started having to do examinations, and there's also a great section on what examinations to perform, which features to look for. So it just flows really, really nicely. As I became even more senior, so back in sort of final year of medical school, I was onto the wards, and I had it in my pocket. It really helped me to look up which investigations to recommend and really become part of the team as well, because I knew exactly what was going on in a really structured manner. As a doctor and as an F1, graduating into the pandemic, everything was really fast paced and we were kind of thrown into it all. And I sort of used it as a step back to make sure that I'd covered all of the points in the clerking. And as mentioned, the treatment algorithm is one of the things I find most useful, because every patient that you see in the acute medicine and A&E, they have their own comorbidities and their own features, and you can really select the right algorithm based on what you're seeing right in front of you, rather than something generic that comes out from a Google search. And it's the confidence that I have in using it, that I know that it's been peer reviewed, that it's based on the latest guidelines. So it's always in my pocket, and I'm just exploring new ways to use it as well. So patient information leaflets. Often I've been on the intranet and I can't find anything that's understandable to even myself. So I know that I can always go on there, print something off. So I really enjoy using it and wouldn't sort of go back.
Thank you very much, Angelica. That's extremely helpful. And you made a very important point, which I was talking largely about clinical decision support. But of course, we know many people use it as an educational resource as well, which we're absolutely delighted about. Thank you. Elva, over to yourself. I wonder, can you tell us about your experience of using the resource, particularly in clinical practice, if you can?
Thanks, Kieran. So I've been using the resource for, I guess, just over a year now, and I guess that's spanned time in acute medicine, intensive care, and now anaesthetics. It's been really useful in a number of respects, and I was going to speak about one case today, but really it's there've been way more cases that the resource has been useful for me for. Patient leaflets in particular have been really helpful. I think, as well as having the resources to allow me to develop my own kind of knowledge from, theory, diagnosis to management, and kind of actually discussing issues with patients. The patient leaflets have given me kind of resources to help explain quite complex issues to patients in ways that they understand. Because as we all know, kind of as healthcare professionals, it's so important that a patient understands what is wrong with them, understands what treatment they need, and is therefore able to provide fully informed consent for that. So I found those leaflets hugely useful. I think super relevant to the past year or two as well has been the application in terms of COVID. As Kieran highlighted in his overview of the resource, this constantly updated evidence and links to really useful resources, be that NICE guidance, Public Health England resources. So in such a fast-paced, kind of quickly evolving condition, using the resources to learn how to manage diabetes properly in a patient with COVID-19, or how to anticoagulate them. I find that really invaluable when we were still kind of trying to formulate policies within our own hospitals locally. And I was able to use these in conjunction with other members of the multidisciplinary team, for example, trainee acute care practitioners. So yeah, I find it hugely useful in multiple respects.
Fantastic. Thank you very much. And you made a very important point there about patient information leaflets, which I possibly didn't emphasize enough, about conveying really quite complex information, and yet in a way that people will be able to understand and make use of, which is a real skill and not easy to do, but very, very important. And also to be confident that the patient information parallels the professional content. Everyone, we might come back to you about your case in a second, but Amal, tell us about using the tool from your perspective.
Yeah, thanks, Kieran. So I've probably been using the tool maybe 3 or 4 years as well, and different stages of my career. So it's been really, really helpful to use it to various different reasons, kind of linked to what's already been said, whether it be actually speeding up diagnosis and treatment, or actually being able to look at some conditions that maybe seen lots of different conditions, doing lots of different patients. It's helpful to focus in on them, because as a generalist, you don't always spend lots of time on one particular set of patients. So I thought it might be helpful just to discuss one case that I saw. So just an example, I was in A&E department, a gentleman comes in, he's got urinary retention, so he's not able to pass urine and not really sure what's going on. He's already on some antibiotics, and obviously he was catheterized, but we need to kind of figure out some definitive plan. So obviously in A&E, it's fast-paced. We need to decide, is this patient staying, is this patient going, can we send them away with treatment, do we need to keep them in? So I thought I'd have a quick look on BMJ Best Practice, use the tool to see actually, is there something we can give this guy to sort things out quickly. Turns out this, looking at the history, symptoms, and the length of presentation, looked like this guy had prostatitis. And so actually, using the tool, I was able to see he was already on the correct antibiotic. This was the most likely diagnosis given his symptoms. So it helped, because it helped me quickly find out what was going on. It also helped me prevent inappropriate prescription of an additional antibiotic. And also in terms of analgesia, so there's different analgesia that would maybe worsen the symptoms in prostatitis. It could increase constipation symptoms and things like that. So it helped prevent prescription of an inappropriate medication as well. And I think the last thing was actually, like I said, it helped prevent a prolonged remission, because if we weren't sure, this gentleman may end up having to come in for more investigations. So it was really helpful on that aspect. So yeah, that was one of the main examples.
Great, thank you very much, Amal. That's really helpful and fantastic. We're including cases as well. Angelica, back to yourself. One thing we hear a lot about is transition from being a medical student through to being a foundation ear doctor. Tell us about the challenges that entails in that, and how you use resources to help you cope with that transition.
So I think one big step, being medical student to junior doctor, is having that responsibility, and you being the first port of call if anything goes wrong kind of on the wards. So I think having that tool, it serves you throughout the whole examination, which investigations to think about. And I think sometimes you can become flustered on the ward. There's a lot going on all the time, and you may miss some quite simple investigations, such as fecal cultures or sampling the urine and sputum. So just having a look at the app, which I use, it really simplifies everything. It also tells you exactly which blood investigations to request, so that when you're doing all your forms online, you're clicking the right things and requesting the right things as well. I had a case as well that I was just going to talk through, and actually I've seen this obviously as a medical student, so had the common scenario of kind of PR bleeding, rectal bleeding, quite a young individual, and they actually had a background of inflammatory bowel disease and ulcerative colitis. So initially we were making sure we've got all the points in the history and doing a thorough examination, but then also moving on to correct investigations in terms of the bloods and sampling the stool culture too. But what I found really useful was then having the scoring system specific to that condition, being able to really implement all the findings from the patient and make it really specific, and then to risk stratify the condition and its severity. And then if you look on the treatment algorithm of this condition on the BMJ Best Practice, it really breaks it down into how severe the condition is, into what features you're seeing with the patient right in front of you, and it tailors the management towards that. And I think another thing that's quite difficult is we have so many apps, that we can use, but there's very rare to have something that's got everything in one place, from whether you want to just have a look at the investigations or the management. And the other thing that I found quite useful is there's for each condition, there's a link for differentials. So sometimes lots of similar conditions can present in similar ways, and you need to consider other things. And if you're really flustered, it can kind of put you on the spot a little bit, but at least you've got this little list to go through, and it tells you why something is more likely to be a certain condition than something else. So I find that really useful. And I think the last thing is, once you've managed the patient, is to think about monitoring and complications as well. And there's a whole section on this. So once you kind of in the acute setting stabilize the patient, it gives you an overview of what you need to do next, which is of course really important, because you'll get lots of senior support in hopefully stabilizing the patient, but then you may have to carry on their care on the ward as a junior. So that's an overview of one scenario.
Yeah. Thank you. That's really helpful, and like, I think it's a very good example, extremely good example of kind of joining things up from history through to then deciding what tests to do, then to assessing the severity, and then you can move to the treatment algorithm and say, well, actually this person has moderate or severe disease, and therefore you go to that aspect of the treatment algorithm, and on from there. It's, once again, it's a step towards personalization of care, which I think is another theme we'll be hearing a massive amount more of over the next 5 or 10 years. Thank you, Angelica. Eva, over to you. You were going to tell us about a case, I think. Tell us about your case if you can. Thank you.
I think I was going to speak about a specific case, but I think, as I said earlier, just the general application, I think for me the most useful thing was use of the resource through COVID, because we were seeing quite a few patients with the same problem, where that when we were kind of in the initial stages of managing it, trying to manage their kind of diabetes control and things like that with the condition. So we were kind of waiting for our local diabetes teams come up with guidelines to kind of monitor and how to manage high BMs. So I just felt like the resource was able to provide kind of, I guess, just links to multiple different resources, which would allow us to back ourselves in the decisions that we were making, because it was so fast, quickly evolving. And you were having to treat patients, but it's always, I think, especially being so junior as well, it's good to have that information behind you. So you make a decision, say, right, this is evidence-based, I'm making this decision. And I think that the best practice was really useful in that regard. So yeah.
Thank you. That's really helpful. Thank you. Amal, back to yourself again. I'm going to ask you about one specific feature, which is multimedia and infographics and flow charts and things like that. Useful, not useful? How do you learn? Do you like things like that?
Yeah, absolutely. I'm more of a visual learner, actually. So seeing, especially when you've got so many patients to deal with, you want to get the information quickly and you want it to be reliable as well. So rather than just Googling a treatment pathway, you want to use something that's reliable. So I use the tool a lot. One of the reasons why we're speaking on here. So having something that can quickly show you what to do next is really, really helpful. And also, like we talked about, being able to personalise it to the patient. So often on the treatment pathways, there's different areas which kind of, it'll say, is it this severity, this severity, this severity? So you can kind of almost tailor pick to your patient's clinical status. Another example, I think, of using multimedia is, say you've got an unusual diagnosis or one that you don't do of so often. So I was in the paediatric assessment area, and a young girl came with an eye condition, and you don't look at them every day. So it was helpful to actually look at some pictures on the tool of actually what could this be before going to have a look. And that, again, that sped up the process of diagnosis a lot quicker, because I had some idea of what I was looking at, because especially eye conditions, you're most likely going to have to get someone more senior or a specialist to look at, but you need some sort of baseline to look at. So it was really helpful in that scenario as well. But I think in general, having something that's got some sort of visual pathway is helpful for myself, but also to showing to others, because using the app, I use it a lot as a doctor, but I think for the nursing team, pharmacy team, even the physiotherapy team, having some sort of reference so you can all get on the same page and work better as a team is really helpful. So rather than just showing people squeals of writing, having some clear pathway, clear diagram to show what you're doing or why you're doing it is really helpful. So it's not just been useful for me, but also working with others actually. So yeah, it's really helpful.
Thank you. Thanks, Amal. Angelica, let me move to another subject which is important, which is kind of speed. People say they want answers fast. How quickly do you want answers? Do you need to get your answers? Is it seconds, minutes, 10 minutes? How long would you spend searching for things?
What I love is that I can just literally, I don't even have to finish writing the whole word, and it already gives me options. And a specific one is kind of things, conditions such as asthma, which have quite an acute component, as well as managing chronic components. But it gives you options whether you want to look at kind of acute exacerbations or chronic management. So I don't even have to finish the search term for the options to be in front of me. And I think that's really important because, as we've all mentioned, being on the wards, it's really fast paced. You don't have a lot of time to spend looking through lots and lots of information, and you just want to get to the bit you need. And sometimes you don't need to go through the whole investigations management. Sometimes you just want something specific, and that's how you can kind of navigate on the app and just click. So if you just want to look at complications, you can just read that section. So I think getting information quickly but also efficiently. So that's why I found that often websites will be really good, but the applications on the phones are not very efficient. But with this BMJ Best Practice, I know that is all on my phone. I don't even have to have good Wi-Fi, good signal. I can always access it. So I think it does really well with being efficient and also really getting to you to exactly where and what kind of information you need. The other thing I'd say about that is it's really well structured, and it's the same structure for each condition, so that you know exactly what the layout is going to be like, so you're not kind of lost looking up a different specialty. So it's really easy to follow as well, and I think that makes me more efficient in day to day.
Yeah, Angelica, you've touched on another very important point there, which is the structure and the kind of the repeatable structure. So in some ways, what I say to people, if you've used it once, you've used it a million times, because when you come back, having looked at asthma and then you look at diabetes, everything is in the same layout, and so it's much faster the second time around, and people get used to looking at it. So thank you, that's very helpful. Eva, back to yourself, and another feature, once again, to touch on multimedia. Sometimes when I talk to trainee doctors and I ask them, how long would you watch a video for? They'll say 90 seconds, which really took me back the first time, because I thought they'd say 20 minutes or 30 minutes or something like that. What about yourself and your kind of learning habits? If you're looking up something multimedia, video based, what would you look for? How long would you watch something for?
I think 5 minutes is probably, I think up to 5 minutes, because in that sense it's kind of short, sharp, kind of delivers what I want to know in a kind of small snippet. So for me, it would be more memorable. So yeah, because I know the resource it's got, especially I guess having just started anaesthetics as well, we've got some of the videos on like bag mask ventilation, for example. They're nice and short, but they're really useful. So yeah, I do like to learn from watching videos, but I tend 5 minutes is kind of my attention span, or 5 minutes or less.
Yeah, and surprisingly, maybe I shouldn't be surprised when 90 seconds and they watch it at double speed at the same time, which I've now started to do myself. Anyways, I heard a timely 3-minute warning. Amal, any or with resource up to now?
I think the only thing that stood out that's been really helpful for me is, I think it's been touched on a little bit, it's just, especially when you first start your career as a doctor in your junior stages, there are going to be lots of things you're unsure about. So don't kind of just encourage people not to be afraid to take time to sit down and even say, I just need to have a look at things, and use tools like the BMJ Best Practice as a point of discussion. So when you're unsure about things, that can be used to kind of discuss different issues with other people, whether it be your colleagues or your seniors, because there will be scenarios that come up where you're not quite comfortable with the diagnosis or a treatment plan. And so this can, or maybe you think you've got it right, but you're not quite sure. So it can increase your confidence a bit and give you a bit of grounding, especially when you do first start out, or when you're in a new specialty, you're in a new job, and you've got lots of other things going on. So don't be afraid to take time just to say, look, I just need to go and look this up, or ask someone's opinion about something, but kind of show your initiative and say, look, I've looked this up, this is on the tool, and BMJ Best Practice is really reliable, so it's a reliable thing to use, so don't be afraid just to take the time to do that. So let's say.
Fantastic, thank you. That's very, very well said, an important point. I think we've got to draw this to a close because I heard a 3-minute warning about 2 minutes ago. So first of all, thank you very much to our panel who made a massive contribution, really, for giving up their own time and for looking at the resource and offering various insights from the learner and practitioner perspective, which are by far the most important perspectives in a tool like that. So we're really, really grateful. In terms of our listeners, once again, please do get in touch. If you Google BMJ Best Practice, you'll find the resource freely available within England and Scotland and Wales. And if you have any problems in trying to access the resource, do get in touch, or any suggestions of how we can do things better or improve the tool in any way, please do let us know. Everything that we've built into the tool over the last few years has been built with the learner and the user and the clinician in mind. The reason why we put calculators in, CME tracker, procedural videos in, is people told us that they wanted them. And so we're very, very happy to hear further suggestions of what people might want from BMJ Best Practice. So thank you for listening. Thank you once again to our panel. And I'm not too sure quite what's going to happen now. Maybe hand back to the moderator.
Thank you very much, Kieran, Emil, Angelica, and Alba. I could definitely empathise with a lot of what you guys have been speaking about, particularly since I'm a new F1 myself, having to look at BMJ Best Practice quite a lot of the time. So thank you so much for sharing your experiences and insight with us today.